So I'm Josh, this is Amanda. We're both foundation trainee dentists right now, and we're going to give you a lecture on dental x-rays. We're going to try and cover the basics of interpretation and common pathologies involved in those as well.
Mhm. So, just to start, the types of radiographs we'll be going over today are bite wings, periapicals, panoramic and occlusal views, cephalometrics, and CBCT.
Cool. So we're going to start by covering the bread and butter of x-rays in dentistry, which are bite wings and periapicals. So bite wings, they're usually used for detecting interproximal caries, which you might not be able to see clinically, as well as assessing bone levels. They're an X-ray you take basically with every new patient you see, just as a baseline as well, which are quite good. So the main pros is they're very good, as I've explained, at detecting decay between the teeth, which you might not be able to see yourself clinically, as well as bone loss as well as monitoring because of them being taken every 6 months if they're high risk caries or every 12 months if they are not. You get to see if there's any changes in the mouth using this. And the main disadvantages of them is you can't really see anything past the crown of the teeth very well. Um, so for any pathology associated with the roots, you wouldn't really be able to see much using those. Periapicals, on the other hand, are used for detecting periapical pathology and assessing bone levels in a bit more detail. So they are basically taken if you're planning on doing any root canal treatment on a tooth, if you're planning on doing any periodontal treatment as well, especially subgingival PMPR. So if a patient, for example, presents with grade 4 periodontal disease, then you would be taking full mouth periapicals for that. So the main advantages of those is it gives you a good detail of the whole tooth you're trying to have a look at, including the crown and the roots, as well as the bone around, which is quite important in giving you a bit more detail in what's going on. Um, and yeah, they're quite good at being able to see any fractures as well as abscesses and the lesions you would see around the roots. The main negative things involved with periapical radiographs is, for example, with gum disease, you're going to need to take quite a few of them as they're quite small films, which exposes the patient to quite a lot of radiation. And it can be quite challenging to place the x-rays as they are quite big and it can be quite uncomfortable for the patient and can trigger quite a lot of gag reflexes in most patients. So yeah, it's quite a bit more tricky compared to bite wings and taking those.
Mm.
Oh yeah, sorry. So these are so, and here we have some examples of bite wings and periapical radiographs. So you can see on the bite wings that very clearly you can see in between the teeth. So if there's any decay there, you'd be able to see it as radiolucencies. And they're quite good at seeing if there's any radiolucencies below previously existing fillings, which would appear as radiopaque. Um, and you can see some of the bone levels as well, but you can't really see the ends of the roots, which is why you would take periapical, which you can see on your right, where you can basically see the whole tooth in question. In this case, it's the lower left six, which has been root canal treated and appears to have quite a large radiolucency associated with the roots of that tooth.
Mhm. Okay, so I'll be going into the advantages and disadvantages of the occlusal and panoramic views. So occlusal views are used for usually detecting unerupted teeth, but it's not limited to lesions, cysts, and tumors. So a good thing about it is that the films that they use are quite broad and wide, so they can capture the mandible or maxilla depending on which area you're taking. And it's a very nice broad view. And it's used for assessing larger lesions or cystic changes. In some cases, it can also detect teeth that are potentially embedded in the jaw or the maxilla, and it can also capture areas that might be difficult for you to visualize with periapicals. So for instance, if you're looking in an area with an edentulous space, a periapical will not have a good enough field of vision for you to see what's actually going on depending on the area of the jaw. The cons of this, however, are there are limited details compared to periapicals or bite wings. So you would not be using this to diagnose caries at all. You would not be using this to treatment plan for any sort of fillings or root canal treatments at all. And it's not ideal for, once again, as I've said, detecting small caries or subtle bone changes either. Then you have your panoramic views. So it's usually in grossly neglected mouths for assessment of wisdom teeth removal and orthodontic assessment. Usually they're not really a diagnostic tool, but they're more so to treatment plan. So if you want to look at the broader picture of a patient, taking one of these views can be extremely helpful. It captures the wide view of the entire mouth, as we'll be showing you in the rest of the slides. So with panoramic views, you can expect to see both jaws, teeth, sinuses, and surrounding structures. It's very quick and easy for initial assessment, and it's good for comprehensive exams as well. Patients tend to tolerate this a lot more because all they really have to do is bite on a bit of plastic, and then the X-ray machine or the panoramic machine will go around their head, and then they'll be able to scan their jaws fully, and it's less so having to tolerate with films or anything that can cause a gagging reflex. Cons, so there is a lower image resolution compared to periapicals or bite wings, so it can reduce diagnostic accuracy. So you would never use these again. You might be able to slightly see some caries or you could see periapical pathology, but it's not ideal to essentially, plan a root canal treatment or determine working lengths with, or determine how big a carious lesion is going to be using a panoramic. You would usually stick to your bite wings or your periapicals. Distortion and overlap can occur, especially at the edges of the image. If you can imagine, you're going around the whole head, so you have a lot of structures around. You've got your spine, you've got areas in your skull that can superimpose on teeth, so it might be difficult for you to see certain things depending on what you're looking for. And for patient positioning, especially in posterior areas, it's a very technique sensitive sort of technique when you're doing the panoramic. So they have to stand in a way that you'll be able to get a clear view. Otherwise, you may end up having a panoramic view that isn't, diagnostically acceptable, clinically acceptable, and you have to retake it again. And with these types of views, they do take a lot of radiation. So you have to bear that in mind if you decide to take them. So as you can see, you've got your occlusal radiograph here. So you can see, if you can imagine again, if you think about your maxilla, and then you also think about how big a size of a film would have to be in order to encapsulate everything, you can see it ranges from 7 to 7, and it's got a clear, nice view of the maxilla. And then as you can see with the panoramic radiograph, you can see it's got all the structures that I just discussed, very technique sensitive. You can see everything you need to. But if you were trying to look at this closely for caries, it'd be very difficult for you to do so. And it would probably be more guesswork than you being able to accurately determine what you need to do in that patient.
I'm going to talk about two other radiographs which are used in dentistry, slightly less in normal general dental practice, but still quite relevant. The first one is cone beam computed tomography, also known as CBCT. They are used usually for locating unerupted teeth or in orthodontic diagnoses as well as in implants and other areas, for example, in cysts management as well, just to see better what's going on in the whole area. The main benefits of it is it gives you a 3D image, which is probably the only X-ray we're going to talk about today which does that. And it allows you basically to see the whole detail of the area you're focused on and the associated areas around. For example, if there's any nerves in the area or anything else you should be aware of, and the proximity of the area of concern to other areas as well. So it's basically ideal for any implant planning and complex orthodontics, as you really need to know how much bone is on either side, and if moving a tooth or placing an implant is a viable option for the patient. The main cons involved with it is quite high in radiation exposure to the patient, as it's constant beam of radiation to take a 3D image compared to the 2D radiographs, the other radiographs we've spoken about basically. And the equipment itself, which is required, is very expensive, so you're quite unlikely to work in a practice which has a CBCT scan. But there usually is a hospital nearby or a practice which will have them, so you would need to refer your patients for that. The other type is cephalometric radiographs, which are also known as lateral kefs. They're mainly used in orthodontic treatment, especially if a patient is potentially going to undergo orthognathic surgery, which involves maxillofacial surgery, basically breaking the jaw, the maxilla, and then changing the arrangements to give the patient a class 1 occlusion. The main advantages of it is it basically gives you a good idea of the skeletal pattern and class of the patient, as well as if there's any asymmetries and growth patterns as well. And it is very helpful in treatment planning the surgery itself for the maxillofacial surgeons. The main disadvantage is it is very limited in its use, so you can't really use it for any detection of caries or periodontal disease, as there's a bit of overlap between both sides because it's a side view of the whole face, but it's very good otherwise for bone analysis. And yeah, it requires precise patient positioning as well. So if you move the patient slightly to one side or the other, you might not get an accurate picture and it can kind of mess everything up. So it's quite technique sensitive. And here you can see some examples. So you can see the cephalometric radiograph or lateral kerf. It gives you quite a good image of the bone and the teeth as well, but you wouldn't be able to really tell much about if there's any decay in the area. And the CBCT, on the other hand, it gives you full different views of the left, the right. You can change, you can add probably more views as well to this. And so it's really good for any treatment planning, especially in complex surgery and in compromised areas as well.
Now we'll be going into some techniques that are commonly used when taking radiographs. So one of them is the bisected angle technique. So this is used for difficult positioning, especially when it comes to patients' teeth. And it's useful when the paralleling technique is not possible due to the patient's anatomy. So for instance, maxillary molars or certain types of angled teeth um, are difficult to kind of get parallel to the film. This provides an adequate diagnostic image of the tooth and the surrounding structures as well. The cons of this is that it can introduce distortion due to angulation, so this may lead to reduced accuracy compared to the paralleling technique. And also, the increased risk of distortion can cause your treatment planning to become a little awry, so you have to just make sure that whatever you're taking, you can marry up clinically as well. Then you have the parallax technique. This is commonly used with impacted teeth, specifically with canines. Sometimes you can use it if you do notice anything suspicious within the mandible or the maxilla and you want to figure out which area it's residing in, whether it be buccal or lingual. So the pros of this is, once again, helps determining position of structures in the jaw. It's useful for locating impacted teeth or foreign bodies. Said those two already. It can assist in identifying whether a structure is buccal or lingual to the tooth again. And the cons of this, however, are the technique requires taking additional radiograph, which leads to increased radiation exposure, and it's more time consuming compared to standard radiographs. So usually with this technique, so for instance, if you were taking a periapical and you wanted to determine whether an impacted canine is residing either, buccally or palatally, or I should say labially or palatally, same is lingual and opposite is buccal. So if we're thinking about the lingual aspect, that would be your palatal. So if you take an x-ray of the tooth twice and you notice that the tooth is in the same area and it hasn't moved, it's most likely that it's going to be on the lingual aspect. If you take the x-rays, two of them, and you notice that the teeth are almost moving away from each other or the tooth is not in the same position that it was in the first x-ray, then it would be more placed buccally. So it kind of helps to determine where exactly a foreign body or an impacted tooth may be, and it's really, really good for treatment planning as well.
So we're now going to talk about the normal variations on the radiograph, which is basically the anatomy. You can see we're going to be using the OPG, which has the most anatomy that you would be able to see on the radiograph. So as it's labeled here quite well, the condyle is labeled in brown, and then the coronoid process is labeled in yellow. The condyle is where the temporomandibular joint is, which is where the jaw is connected to the rest of your head. And the coronoid process is where there's quite a few muscle mastications which attach to that area.
So as you can see with the red line, that is known as the glenoid fossa and is also known as the mandibular fossa. And it's a depression that's located around the temporal bone, which is a bone within the skull there. So that's a normal variation that you would see in an OPG.
Cool. And as you can see, labeled in purple is the articular eminence, which is a part of the temporal bone. when you open your mouth fully, your jaw, the condyle of the jaw, basically slides over it, which causes you to open as wide as you can.
Mhm. And then we have in almost like a light blue, the ramus of the mandible. And in green, we also have the body of the mandible. And where these two anatomical structures meet is known as the angle of the mandible, which is depicted in the purple line. Again, very common normal variation on a radiograph.
Cool. And you can see labeled in red, kind of like a tunnel, that is where your inferior alveolar nerve would lie. So it's the inferior alveolar nerve canal. And then the blue dots you would see on there as like black areas usually is where the mental foramen is, which is where that nerve exits to create the innervations in your lips and your chin area.
And then as you can see, you have these large radiolucencies and you see them around the top in the maxilla between about the 6 to 8 region. You'll see a radiolucency there, and those are your maxillary sinuses. Again, completely normal variation on a radiograph. And it's also good to determine how close roots are to the maxillary sinuses when you're treatment planning.
Cool. And you can see here the zygomatic process in a red line. This one is a bit confusing. Sometimes people think it is linked with the maxillary sinus. You'll be able to see the sinus by just following around the margin. This one will see it's a bit more of a direct angle, as you can see on the label. This is basically your cheekbones bone you can feel in your face.
And then you have your hard palate depicted in green. Usually it'd be quite almost like a white thickness, and you'd usually see it between 7 to 7. That's the hard palate. Once again, completely normal variation that's seen on most OPGs.
And on this one, a bit more spicy, you can see mandibular tori, which are, if you have a look between the lower threes and fours on both sides, there's these circular radiopacities, which is basically hard area of bone, which is corticated. It's completely fine, is doesn't have any symptoms. It's usually left alone because it doesn't cause any pain. It tends to grow with age sometimes, or it can just stay the same, usually leave them. There are sometimes signs of palatal tori as well. So you basically the same on the top teeth area.
Okay, so we're going to be going into the radiographic regulations. So enjoy. So the first one we have is the IRMER 2017, and this focuses mainly on patient safety. So your key principles are justifications. So you really need to talk about why you're taking these radiographs and do the clinical benefits outweigh the radiation risks. That's a really, really important part of taking a radiograph. And then optimization, which is important, which goes into more so the radiographic, the radiation dose that you're giving to a patient. And then also limitations is also a key principle. So it prevents unnecessary exposure by setting those constraints, especially for children and pregnant patients. Yeah.
Cool. I'm going to be speaking about the IRR from 2017, which is basically a bit more linked to the workplace regulations for radiation safety, not only to the general public, but also to the staff. So that basically involved having controlled areas in your practice where there is the X-ray. So you'd have like an X-ray room, which is clearly labeled with warning signs as well to let everyone know that there's radiation happening in that room, and as well as radiation protection supervisors. So every dental practice must have someone as a radiation protection supervisor, which is often going to be a senior dentist to ensure compliance and to make sure everyone stays safe around radiation, as well as personal monitoring. So staff using X-ray frequently should wear dosimeters to monitor radiation exposure. This is usually in more hospital settings where you get radiographers, which are it's all they do all day is radiation radiographs. They'd be exposed to slightly more X-ray radiation. You'd also need to do regular equipment testing, and it basically gives you the regulations on how often you need to do that.
So we're also going to be going into radiographic quality and errors. So obviously with every X-ray or radiograph that you take, it may not be perfect. So one of them that we commonly see is exposure errors. So this is related to incorrect X-ray settings. So making sure that your X-ray radiation or the exposure, if it's not at the correct level. In practice, we actually have a machine that you press specifically on the button of which type of X-ray you're going to take. So for instance, if you press the wrong one and you take the X-ray, you won't be surprised to find out that your X-ray may not be as clinically acceptable as it should be. This can result in images that are too dark, which means that they're overexposed, or too light, which means they are underexposed. So a couple of examples here. So overexposure means that you have images that are too dark because there's excessive radiation, and you have underexposure where the image is too light, so it makes it difficult to see any details within the radiograph. So usually the solution is to just adjust the radiation or exposure time, and you take into consideration the patient size as well.
Cool. So another type is positioning error. So this is quite common, especially at the start, and then as you progress in your career and you develop yourself, you develop the skills and you kind of understand a bit more the relativity of the teeth and your X-ray film as well. So it's usually caused by placing the film incorrectly or in an area where it doesn't quite capture what you're trying to get. Um, it can be the film, but it can also be the X-ray beam itself. This can lead to distortion and missing anatomy and even artifacts developing in your X-rays. Artifacts are basically areas where something that is not actually there clinically appears on the X-ray, which can cause a bit of confusion as well. An example of this is cone cut. So there's basically a clear, unexposed area due to improper alignment of the collimator. So basically, it's an area where the film wasn't hit by any radiation from the collimator. So with that, main thing to do is to angle, make sure the collimator is placed properly, and having the rings which help you aim it better. There's also foreshortening, which is excessive vertical angulation. So basically, if the film is facing this way and the collimator is facing this way, it can make the teeth look a bit stubby and short. There's elongation, which is the opposite way. So it's insufficient vertical angulation and making the teeth appear too long. The solution is basically using a beam, collimator, and correct angulation, which is usually helped by having a ring attached to your film holder.
So another thing that we look into is quality and errors. So processing errors is one of them, and this is mainly in film-based radiography. You usually get issues during developing, fixing, and handling during film-based, and it's mainly relevant for traditional film radiography, but some of these principles do apply to digital imaging also. So there may be faults potentially with your processor, and these kind of work in tandem or very similar to what would happen in traditional film radiography. So a couple of examples to go over is the dark film. So if it's overdeveloped, you'll see there's an excessive development time or high temperature. You've got your light film as well, which is underdeveloped, so you'd have insufficient development time or cold solution. Film fogging, so you can have an exposure to light before processing. And then the solution for all of these really is just to follow your protocol. So if you are doing film-based photography, proper darkroom protocols, and with digital handling techniques and just ensuring that your processor is working well.
So I'm going to talk about handling and equipment errors as well. So this is related mostly to sensor and film mishandling and artifacts or equipment malfunction. The main examples of these are scratched or damaged sensors or films. This can cause unwanted lines or marks on the images, which can be artifacts, which might cause misdiagnoses, and it can also interfere with your own diagnosis if it's blocking an area you need to see properly. Another common type is double exposure, so using the same film twice, which commonly occurs when you're taking format Ps because there's quite a lot of films going around. Best way to avoid that is just keeping the films you've used to one side to make sure you don't pick from that pile again. If that does happen, you're going to have to take a new X-ray, as that X-ray will no longer be fit for diagnosis. Another main type is artifacts. For example, jewelry is the most common one, and sometimes lead apron interference can create unwanted shadows, which can affect the diagnostic ability of you and looking at the X-ray. Solution as well. So the handle sensors carefully and remove obstruction before exposure is very important to make sure you do a good job. You're unlikely to see these in practice nowadays as they're getting phased out slowly by the more digital X-rays available nowadays.
So we're going to go through a couple of radiographic errors with you. So for the first one, as you can see, there's an OPG in front of you, and you can see that there are semicircles almost hovering over the image. If you look at the patient's ears, you'll notice that they're wearing earrings, and because of that, the machine has detected it and superimposed it over the image. So this will make it very difficult for the clinician to determine what they need to do, whether it be treatment planning or potentially trying to find any areas of pathology that they may need to diagnose and potentially even move further to surgery. So it's always important, if you're taking an OPG of a patient, to make sure that their jewelry, any earrings are removed, anything that can interfere with the image is removed.
Cool. And in this example, you can see there's quite a bit of fogging going on in the area, especially on the top part of the bite wing. This is most likely due to light exposure during the processing phase. Best thing to do is make sure you don't open the X-ray film prematurely and expose it to light, because this is what will happen, and you'd have to take the X-ray again, as it's unacceptable diagnostically.
Mhm. So as you can see, these are periapicals, and they're supposed to be periapicals. So if you look on the if you look on the left-hand side, you'll notice that only the crowns are being seen. You also notice on the lower portion of the X-ray that there are no teeth there. So it can be quite difficult in general practice or in hospital to take radiographs for patients who don't have any teeth to oppose the film. Obviously, when you're taking an X-ray, the patient has to bite together, and that sort of stability enables you to take the picture. In this case, it's very difficult to do so because if you don't have any teeth at the bottom, the film shifts and so does the block. So it's very difficult to get the apices of the teeth. So in this case, depending on what they're looking for, they were looking for the apices or any periapical pathology, or even bone levels, because you can see that the bone has depreciated within the X-ray. They would have to take that X-ray again to make it clinically acceptable or diagnostically acceptable, depending on the situation. If you look on the right-hand side, you'll also notice there's a periapical radiograph being taken, and you can see that the incisal edges of the teeth have been almost cut off. And then if you look on the other side of the X-ray, you can also see that there's superimposition. So main issues with this really is the superimposition, because you wouldn't be able to detect caries, and if you couldn't see them clinically and you were hoping to look at them on a film or an X-ray, it'd be very difficult to determine that as well.
Cool. And in this image, you can see on the right-hand side, it looks quite white to the point where you can't really see what's going on in that area. This is most likely due to underdeveloping during the processing phase, um, which again can be avoided by following the protocol correctly.
And then as you can see, this is a periapical, and you can see almost like a dark horizontal line going through the film itself. So this is quite common actually. The radiograph is actually bent, but it bent probably at a period not when the film was being taken, but at another occasion. So because you've taken the X-ray, that area can't really pick up any radiation coming from the X-ray machine. So depending on where that line is, this could be clinically unacceptable, because if you can imagine, if that line were on the apices of the teeth and you were trying to figure out if there was any periapical pathology there, it may be a bit unclear for you. In some cases, some clinicians would retake it depending on what they're trying to do. If not, then they would just have to maintain the fact that if the patient doesn't want to be exposed to radiation, unless they absolutely need it clinically, then they could attempt to retake that again.
Cool. And in this image, you can see two which is next to each other, the normal one being on the left and the distorted one being on the right. So you can see the roots look a lot more curved on the right-hand side one. This is most likely due to the film bending during the X-ray taking part. In this case, depending on what you were looking for, you might have to take the X-ray again, mainly because in the periapical, you can't quite see the apices because of this.
And then as you can see, I think we've got a couple more PAs. So as you can see on the left-hand side, the periapicals are quite short for the anterior periapicals. Maybe it could be improper impositioning of the film. It could be that the patient maybe before they decided to take the X-ray, opened their mouth a little bit and shifted the bite block and the film down, so you weren't able to see the apices of the teeth. So in that case, you would have to retake the image if that's what you're looking for. When we then look to the x-rays on the right-hand side, you can see there's superimposition everywhere. So it'd actually be a nightmare if you're trying to determine if there are caries in between the teeth. If that's what you're looking for, you're definitely going to have to retake those again.
Cool. And in this one, you can see on the left-hand side of the bite wing, there appears to be quite a white cut-through area. This is due to cone cut, so that's mainly due to the collimator not being directly onto the film. This can be changed by making sure you have a ring around your X-ray film holder to make sure it's easier to angle the collimator to get a good image, good angulation on the X-ray film itself.
Good. And then as you can see on these x-rays, it looks like there is a little bit of underexposure. So because of this, the film appears to be a lot whiter in color. So if you're looking at the left-hand side, they're a lot whiter, but if you look around the apices, it's quite difficult to tell what's going on around there. And usually you'd want a clear image. You can even see or appreciate that if you're trying to look at the three, it's almost erased from the picture and it's almost kind of been kind of ingrained into the bone. So you can't exactly see all of the structures of that tooth. So once again, if you were looking for that tooth, or if you wanted to clinically diagnose what was going on with that tooth, you would have to take another x-ray. And then as you can see on the right-hand side, again, everything looks very, very white. So it'd be very difficult to determine any pathologies there as well.
Okay, and on this one, it's the opposite. So it's being overexposed quite substantially, which means you can't really see much because it just looks a bit black. You can just about see the apices of the roots in this PA, but obviously if you're looking for any coronal pathology, you'd have to take it again. So we're also going to briefly touch upon some common pathologies which can be seen on OPGs. I'm going to start off by talking about odontogenic keratocysts, which you can see on the left side of the bite wing, which is on the right side of the screen. It looks like there's a multilocular lesion.
You said bite wing though.
Huh?
You said bite wing.
I said bite. I thought I said OPG.
It's that time. I know.
Oh
It's that time
no.
of the day.
So we're also going to briefly touch upon some common pathologies, which can be seen on OPGs. So on this image, you can see odontogenic keratocysts. This can be seen on the left side of the OPG, which is on the right-hand side of the screen. It looks like a multilocular radiolucent lesion. They are usually seen in younger patients and can tend to reoccur. If you see this in general practice, you most likely have to refer that in to maxillofacial surgery or oral medicine.
And then here we have a periapical cyst. So if you look on the lower left-hand side, between the 4 and the 5, the ones that have been root canaled and crowned, you'll see a unilocular radiolucency surrounding the two teeth. So in this case, you would usually refer on to oral surgery because it is due to the dentition. Most of the time it's not sinister, so it's nothing that you'd worry about if it were with regards to cancer. Either way, if you have any findings that may make you assume that it may be towards the cancer route, you would go down your 2-week pathway. In most cases, what the oral surgeons would potentially do is remove the teeth, depending on if the patient would like to save the teeth or not. I think in most cases, this tooth would be taken out though. But I know some very ambitious endodontists could try to save the teeth and potentially remove the cyst as well.
Yeah, and on this OPG, you can see there appears to be some missing premolars on the mandibular arch, which would be the lower right 5 and the lower left 5, sorry. In this case, best thing to do is to refer the patient onto orthodontics as they might be able to shift the teeth around or advise the patient whether they need to get a bridge, for example, placed or any type of other restorative work done.
Okay. And as you can see, we've got microdontia as well. So it's usually when you have smaller shaped teeth, than you would usually see in nature. So from this radiograph, I can only assume that it would be the upper left tooth. You can see that the tooth is slightly smaller. Sometimes you'd consider it to be a peg lateral, and this would be something that you would go ahead either to restorative, or if you feel like you have the skills, deal with in general practice.
In this case, you can see what appears to be an impacted canine with a brace attached to it and a chain. So this is usually done for orthodontic treatment to get the canine out. The patient is usually referred to oral surgeons, which expose the canine and then place a bracket and attach it to a gold chain, which then slowly pulls the tooth down into the arch. So thank you for listening to our talk. If you'd like to join the WhatsApp, this is the QR code. And if you have any further questions, please leave a comment below.
And here are the references. Thank
Thank
you.
you. Bye.